All right, good evening, everyone. I wanted to welcome you all to this year's Nebraska Oncology Society Evening Speaker Series. So pre-COVID, the Nebraska Oncology Society would meet regularly to discuss different topics in oncology. However, since the beginning of the pandemic, we've been able to pivot to a virtual setting until we are able to meet in person. Our first topic for this year is lung cancer. So here is our agenda for tonight's event. I want to thank this evening's exhibitors and encourage you to visit their booths on the virtual platform. With this format, I just wanted to go over a few housekeeping items. First is we are using Zoom. You can find all of your webinar controls by hovering over the lower section of the Zoom screen. You'll find your microphone, webcam, and chat box options, among other things. Please make sure that your microphones are muted throughout the meeting. If you need to ask questions, please use the chat box or wait until the Q&A session to unmute yourself and ask your question. We'll address all questions at the end of the presentation. You can also use the chat function to send messages privately to individual attendees. If you're having any technical difficulties, please close your browser and use the link to access the webinar once more. Otherwise, feel free to send me an email. The presentations are being recorded and will be uploaded to our event website. We encourage the use of webcams if you're able to, in order to help have more of that face-to-face atmosphere throughout the meeting. And I also wanted to remind you to use the virtual platform to visit our exhibitor booths. You can chat with company representatives live, so make sure to take advantage of that opportunity and thank them for their participation tonight. Without their support, the Nebraska Oncology Society would not be able to carry out its mission of enhancing patient care through oncology research, education, and healthcare legislation. We also encourage you to participate in our competition. Each exhibitor booth has a unique competition code located somewhere in their virtual booth. If you're able to find 5 of these codes and email them to me before the end of the day, you'll be in the running to win a $100 gift card. 1.5 CME credits are available for this event. You can complete the evaluation at our event homepage to get your certificate, and this will be available on our website tomorrow. And then we are also having 1.2 contact hours of nursing hours for any nurses who are joining us today. And with that, I want to now introduce our first speaker, Dr. Julie Brommer. Dr. Brommer is the Director of Thoracic Oncology Program and the co-program leader of the Cancer Immunology Program and professor of the oncology at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins. She directs the Kimmel Cancer Center at the Johns Hopkins Bayview campus and is a co-principal investigator on the Johns Hopkins National Clinical Trials Network. Dr. Brommer received her undergraduate degree in chemistry and philosophy in 1989 from Creighton University. So Dr. Brommer is actually a Nebraska native. And she went on to receive her medical degree from the University of Nebraska Medical Center in 1993. She completed her internship and residency in internal medicine at the University of Utah, and later became the chief medical resident until moving to Baltimore to complete her fellowship in medical oncology at the Kimmel Center. Dr. Brommer is an active clinical leader in the treatment of lung cancer and mesothelioma. She leads the organization of the Multidisciplinary Thoracic Malignancy Conference, whose members meet weekly to discuss thoracic malignancy cases that need multidisciplinary review and approach. Dr. Brommer's research and clinical practice focuses on the development of new therapies for the treatment and prevention of lung cancer and mesothelioma, and her research interests include leading early phase immunotherapy trials of anti-PD-1 antibodies, international phase 3 studies of immunotherapies in lung cancer, and investigator-initiated trials evaluating epigenetic therapies in combination with immunotherapies. Thank you for joining us tonight, Dr. Brommer.
All right. Well, thank you very much for that introduction, and welcome everyone. And I thank you for attending. It's great to be back virtually, but I can tell you I'm actually in Nebraska right now visiting my parents. I'm originally from Wisner, Nebraska, and I'm just trying to open my, and so glad to be back. I can tell you with my travels and where I work, there's still no place like Nebraska. So thank you very much for allowing me to present to you tonight. I'm going to focus on non-small cell lung cancer across the gamut, mainly focusing on immunotherapy, but I will briefly talk about targeted therapy, particularly for early stage as well as metastatic disease. Now let's see if I can get these are my disclosures. So early stage disease this treatment setting is rapidly changing with the advent of immunotherapy in the adjuvant setting, osimertinib for EGFR mutated disease, and we'll briefly talk about neoadjuvant immunotherapy and chemotherapy that was just FDA approved for use for this week. We'll also talk about locally advanced disease, and then lastly, advanced disease, and talk definitely about how this treatment landscape has significantly changed over the past 10 years from what was felt to be extremely dismal to at least a time where patients can live long-term with their advanced disease. So with resectable non-small cell lung cancers, we're talking about mainly stage 2 and stage 3A where adjuvant therapy is used. We will talk about neoadjuvant therapy and then also adjuvant targeted therapy. So for surgically resectable non-small cell lung cancer, we've had in our back pockets adjuvant chemotherapy, and thus far up until 2 years ago, we had nothing else to add after patients underwent surgery. And as in ECOG 1505, adding bevacizumab did not improve outcomes. And really, we were stuck for a very long time in the adjuvant setting. But with the advent of ADURA, the study that was presented by Dr. Herbst in 2020, we now have adjuvant osimertinib for those small group of patients with EGFR mutations. Again, this was a study taking patients with stage 1B through 3A with EGFR mutations and randomize them after surgery or also allowed adjuvant chemotherapy. They were randomized to either receive osimertinib or placebo. And we can see here, particularly for those patients with stage 2 through 3A, we have a significant improvement in disease-free overall survival with a hazard ratio of 0.17. And then when you added in to the disease-free survival curve, including stage 1B disease, they too had a significant improvement in hazard ratio and improvement in disease-free survival, as you can see here. And this improvement at 2 years was seen across the different stages, and thus led to the FDA approval based on these data. Obviously, a lot of folks are waiting for overall survival data as well, but I can tell you in my clinic, I am giving patients adjuvant osimertinib if they have EGFR mutated disease. Of note in the ADURA trial, it also had a significant improvement or decrease in CNS relapse as well. So these patients are more prone to develop CNS relapse. And when you treat with osimertinib, this is significantly decreased. Also last year, immunotherapy was resulted looking at adjuvant atezolizumab in the the Empower 10 study. Dr. Wakely presented this at ASCO last year, showing that in patients after resection, they underwent chemotherapy and then were randomized to atezolizumab or best supportive care. The primary endpoints here was disease-free survival, looking at those patients with PD-L1 positive disease in stage 2 and 3A, but also looked at the ITT population. And you can see here with a median follow-up of almost 3 years, you have a significant improvement in disease-free survival in those patients with PD-L1 positive disease, particularly in stage 2 through 3A, with a hazard ratio of 0.66. If you look here at the middle bar, you also have a significant improvement in disease-free survival. And then if you looked at the ITT randomized patients looking at stage 1B through 3A, you can see here the stratified hazard ratio was 0.81. Now, they did also look by PD-L1 status, and the biggest result was in the, and significant, was in the PD-L1 positive patients. You can see here, including, this trial did include EGFR and ALK positive patients on the top here. And then if you took out the EGFR and ALK positive patients, you can see the data on the second graph below. Now, this trial did lead to atezolizumab approval for those patients with PD-L1 positive disease after surgery and after adjuvant chemotherapy. And so certainly in this group of patients, this is an option. Now, KEYNOTE-091 results are coming and hopefully will be presented at virtual ESMO over the next month or so. And pembrolizumab has shown results in the adjuvant setting as well. This was a study, a phase 3 study for stage 1B through 3A. Patients were randomized to receive pembrolizumab for 1 year or placebo. And this study is reported to have met its disease-free survival endpoint in the overall study population. Interestingly, of note, the improved disease-free survival in patients did trend to be positive in the TPS greater than 50%, but this was not statistically significant. So we're certainly waiting for this data to be fully presented soon. Now, what about neoadjuvant therapy? As you may or may not know, on March 4th, 2022, the FDA has approved for use neoadjuvant chemotherapy plus nivolumab. And this was based on several studies, most recently, and will be reported in the Checkmate 816 study, which I'll briefly go over. But I wanted to give you a little bit of a history. Our group, as well as the group at Memorial Sloan Kettering, first reported neoadjuvant nivolumab blockade in resectable lung cancer several years ago, showing that we can get a response in patients with even single agent IO. And in this small study, it did not lead to any delays in surgery or significant toxicities. The group out of Spain looked at adding nivolumab to chemotherapy prior to surgery for 3 cycles. And this gave us some tantalizing data of a PCR rate of nearly 63%, as you can see here. And these patients did well, and that led to the Checkmate 816 study. Now, in this study, it took patients with large stage 1B based on the 7th edition TNM staging of greater than 4 centimeters all the way through the stage 3A disease, and randomized them to receive nivolumab plus chemotherapy for 3 cycles versus chemotherapy. And adjuvant therapy was not given, which is different than some of the other studies. Now, Dr. Ford out of our group presented at AACR last year the first primary endpoint in the whole patient population that showed an increased PCR rate compared to chemotherapy alone if you added nivolumab. Interestingly, at that point, the event-free survival primary endpoint was not mature yet. However, this is mature now and does show an improvement in event-free survival in nivolumab plus chemotherapy treated patients in the neoadjuvant setting compared to chemotherapy. but we are still awaiting the full data, which we hope will be presented soon, most likely, we think, at AACR. And this is the first regimen that is now approved for use in the neoadjuvant setting. Now, what about locally advanced non-small cell lung cancer? Now, these are patients with unresectable stage 3 disease, and we look to the PACIFIC data, where durvalumab is FDA approved and based on the PACIFIC study. And at 5 years, we see a significant improvement in overall survival as well as progression-free survival, as you can see here. The overall survival data at 5 years is certainly a significant advance for those patients who have a stable or response to definitive chemotherapy and radiation when receiving durvalumab. But when should we start IO after radiation therapy? And recently I was asked this question and presented this at our targeted therapies meeting. And the group who looked at PACIFIC, and this was recently published both at and presented at ESMO Lung Cancer in 2021, as well as ELCC in 2021, there was a trend towards improvement in outcomes if patients received durvalumab within 14 days of finishing radiation therapy and chemo. But there was not an increase in toxicity, which we always worry about. But interestingly, if you look at the whole group, most of the patients received about a median of 52 days after radiation therapy, and only about 35% actually started durvalumab within 42 days. The shortest median was in France at 39 days, and the longest was in the Middle East. So, and what should we do with these patients who recur either on immunotherapy or for a short period of time after stopping immunotherapy? And we don't have any clear guidance. In this recent publication and presentation, they looked at those patients who were on the durvalumab arm and then who received subsequent therapy, and only about 12% of patients received subsequent IO. And half of these recurrences on the durvalumab arm occurred quite quickly after finishing durvalumab itself, so very short period of time. So we still don't know what to do with these patients when they do recur, and how well does immunotherapy control the disease if you try it again. So hopefully some data to come. What about giving patients with EGFR mutations durvalumab after definitive chemotherapy and radiation? Patients with EGFR mutated disease were included in the PACIFIC trial, but there is certainly questions about giving immunotherapy to these patients. And this was one study published by the group out of Stanford, where they collected 37 patients with EGFR mutant disease who received chemotherapy and radiation. 13 of these patients went on to receive durvalumab. 5 of the patients progressed within 12 months of therapy, and 5 patients stopped due to immunotherapy adverse events. And one thing we always are concerned about is about the toxicity that can occur when you start osimertinib, which is pneumonitis, which can occur, and is that increased after or during immunotherapy? And yes, that is true. They did have one patient who had grade 4 pneumonitis when starting osimertinib. So certainly over time, as you can see here, we have seen significant improvements in outcomes in the patients with locally advanced disease. Now with a median overall survival in the PACIFIC study using durvalumab in the consolidation setting of now 47.5 months, so nearing 5 years, with a 5-year overall survival of 43%. So what about advanced stage disease? Certainly this will be the majority of my talk since most of our patients present with advanced stage disease. And certainly we all know therapy decisions are based on histology, and then whether or not a tumor has a mutation, particularly in never smokers or patients with adenocarcinoma, and then how much PD-L1 protein is present. Certainly, over time, we've seen this pie chart grow longer, and certainly the list longer and longer of potentially actionable gene alterations. Certainly, EGFR, KRAS are some of the most common gene alterations where we have targeted therapies now for, but certainly there's a laundry list of mutations or fusions that can be now detected and have targeted therapies for these. Certainly, biomarker testing in advanced stage non-small cell lung cancer is key. Certainly, we have targeted therapy options for the most part in the first line treatment setting, though we do have in the second line treatment setting for KRAS G12C now with sotorasib, as well as amivantamab and mobocertinib for those patients with EGFR exon 20 insertions. But a lot of folks ask about, do we really need to check for these mutations if we have PD-L1 negative or PD-L1 positive disease? Can't we just start chemotherapy and immunotherapy? And one thing we want to point out is that about 27% of patients with PD-L1 positivity do have actionable genomic targets, where it would be very complicated to start them on TKIs if you already have them on immunotherapy or immunotherapy plus chemotherapy due to potential cross toxicity problems. Certainly, PD-L1 tumor proportion score in the absence of genomic testing does not end the diagnostic odyssey for these patients. We really need to know the genomic landscape in those patients with adenocarcinoma. And I would also say for those patients who are never smokers who have squamous cell carcinoma as well. So just to kind of just briefly look about the effect of immunotherapy by driver oncogene. Now, patients with KRAS mutations clearly do benefit from immunotherapy in the first line treatment setting, and we have yet to see data comparing TKIs versus immunotherapy and chemotherapy in this setting. Patients with EGFR mutations do have a very low response rate to immunotherapy. Certainly for those patients with BRAF mutated disease, immunotherapy can be considered in smokers. I do have some patients with BRAF V600E mutations who were smokers that can do well with immunotherapy, but I usually start with TKIs. Certainly MET exon 14 skipping mutations, we don't have a ton of information, but response rates are relatively low. And certainly those patients with ALK, RET, or ROS1 fusions, they do tend to have poor outcomes with immunotherapy, regardless of PD-L1 status. And this is another article out of the ASCO Education Book of 2020, just showing that the response rates in most patients with targetable mutations are quite low, particularly those associated with never smoking. So what about the majority of our patients who don't have driver mutations? I think I feel sort of like a kid in the candy store in the fact that I have many choices to use for our patients. And I do use PD-L1 status to help guide me what to use in the first line treatment setting. And we do continue to have single agent PD-1 or PD-L1 therapy for those patients with high PD-L1 expression. We have pembrolizumab with the 5-year overall survival data. Who thought we'd be talking about 5-year survival back when I graduated from UNMC? But here we have 5-year overall survival of about 32% in those patients with high PD-L1 disease in the first line treatment setting. And then we also have data from a new kid on the block of cemiplimab. This is the MPOWER study that also showed in patients with high PD-L1 an advantage of receiving this PD-1 antibody compared to chemotherapy as well. And then we also have data showing that patients with high PD-L1 disease treated with atezolizumab in the first-line treatment setting compared to chemotherapy does improve survival as well. So certainly, looking at this group of single agents, we have very similar results across the studies with response rates ranging between 36 to 46%, with a progression-free survival of anywhere around 8 months, and then overall survival median in the 20 to 26 month range with significant hazard ratios. So what about IO chemotherapy combinations? Sometimes it's just easier. Could you just give chemotherapy IO to everyone regardless of PD-L1 status? And I'll show you some comparative data, but certainly we'll look at these 4 studies. In this group of regimens, the FDA approvals are for those patients with no EGFR or ALK alterations and are PD-L1 agnostic, in the fact that overall survival benefit was seen across all subgroups. Probably the most that comes to mind, and a lot of us use in the chemo IO setting for patients with non-squamous cell histology, is the Keynote 189 study that looked at pemetrexed, carboplatin, and pembrolizumab compared to chemotherapy combinations. And you can see, we all know that this showed a significant improvement in survival, about a 48% response rate looking at the whole group. And we saw a survival advantage across the different PD-L1 status, as you can see here. The certainly the median duration of response in those patients with high PD-L1 was 15 months. And here we see an overall response rate of 62% in the chemo IO treated patients, in those patients with PD-L1 high disease. So certainly compared to single agent immunotherapy, we have a higher response rate when you add chemotherapy to pembrolizumab in the PD-L1 high disease. But again, you see an overall survival advantage across the different PD-L1 status groups. What about the MPOWER 150 study? Now, this was a more complicated study, but adding atezolizumab, bevacizumab, carboplatin, and paclitaxel. This regimen is the only study that included those patients with EGFR mutations, which I do think is significant to note. You can see here the 4-drug regimen compared to the chemotherapy plus bevacizumab arm had an improved objective response rate and an improved overall survival, particularly in those patients with PD-L1 high disease. And you can see that here. I think the response rate in the middle with PD-L1 high here of almost 70% is significant to note here. Now, what about using NAB, paclitaxel, and carboplatin, and atezolizumab? And this is the MPOWER 130 study. And this regimen compared to chemotherapy, and we have a hazard ratio of 0.79, certainly a significant improvement in response. And you can see here the different subgroups. Certainly, if pemetrexed is not an option for a patient, certainly NAB, paclitaxel, carboplatin, and atezolizumab could also be used. You can see here certainly the lot of the progression-free survival data, particularly in the PD-L1 high disease group here, and we did see a particular hazard ratio interesting across the different subgroups. So if you look at the non-squamous histology studies, you can see here the biggest bang for our buck, I think, in the overall survival is in the Keynote 189 and MPOWER 150 study. The hazard ratio in the Keynote 189 is hard to beat of 0.59. But certainly the response rates of 62% and 69% in PD-L1 high disease is certainly tantalizing, particularly in those patients that we really need a response. What about for squamous cell histology? This is the only chemo IO regimen that is approved for use across the PD-L1 status. Response rates in PD-L1 high of 62%. You can see here the overall survival data in the squamous cell population does show an improvement in overall survival when adding pembrolizumab to paclitaxel or now paclitaxel with carboplatin. And what about IO combinations? You know, where does ipilimumab and nivolumab fit in? Certainly it's approved for use for patients with PD-L1 positive disease based on the Checkmate 227 study, and we do have 3 and 4 year data. Certainly, though not designed to evaluate this directly, but there was an improvement or trend towards improvement in survival in PD-L1 negative disease. You can look at across histologies here in PD-L1 positive versus PD-L1 negative. We have 4 year survival now. And then here with PD-L1 high disease, you can see here in the nivo-ipi, the hazard ratio for that treatment group was 0.66 compared to chemotherapy. You can kind of see here in the, interestingly, we have a 4 year survival of 37% in nivo-ipi treated patients with PD-L1 high disease, nivo only treated patients of 26%, and then chemotherapy treated patients of 20%. So, and also if you look at the PD-L1 high disease, here you can see the response rate of 45% in nivo-ipi compared to about 37% versus 36% with just chemotherapy. And you can see here the hazard ratios and the 5 year progression-free survival rates. But I think, you know, when should we use IO combinations? It's, you know, if you look at Keynote 024 versus Checkmate 227, you know, we don't yet have 5 year data out of Checkmate 227. Hopefully this is coming soon. But we'll see if the answer is in the tail of the curve, and potentially maybe this will flatten out compared to the Keynote 024 study, but we shall see. What about Checkmate 9LA? This study was presented and FDA approved in May 2020, and we've seen continued updates. And this study gave only 2 cycles of chemotherapy with nivolumab and ipilimumab, which is attractive for a lot of our patients where we feel like we have to add chemotherapy, particularly for those patients with PD-L1 negative disease. And we have a significant improvement in hazard ratio here. And then with the 2 year survival of 38% versus 26% for chemotherapy only. And the hazard ratio continues to be significant. The duration of response is appealing of 11.3 months in the nivo-ipi chemo arm versus the chemotherapy only arm. And here is the data for PD-L1 high disease, where you can see it does also favor across the different PD-L1 subtypes of nivo-ipi plus chemo versus chemo. So if you look at PD-L1 high disease across the histologies and now add on the nivo-ipi Checkmate 227 data versus nivo-ipi chemotherapy in the Checkmate 9LA data, really the overall survival is still, I think, in my mind, favors pembrolizumab. But certainly nivolumab and ipilimumab would be also an option. We have a progression-free survival very similar across all of the different arms, and a very similar response rate with single agent pembrolizumab compared to ipilimumab and nivolumab in the PD-L1 high disease. Median duration of response is relatively similar, though a few months longer in those patients treated with nivolumab and ipilimumab on Checkmate 227. But still, in my practice, I mainly use pembrolizumab as a single agent in those patients with PD-L1 high disease. What about for PD-L1 1 to 49? This is really the unmet need, where we can use either IO plus IO, IO plus chemotherapy, or IO plus chemotherapy based, and the chemotherapy backbone based on the histology. What about for PD-L1 negative disease? So I pulled out these sub-analyses out of the presentations. And if you look at the Checkmate 227 or Checkmate 9LA data in patients with PD-L1 negative disease, the overall survival is about 17 months. Progression-free survival, very similar. Response rate, very similar. Duration of response, very similar. But if you look at broken out by histology, and then you layer in the keynote studies, as you can see, again, this is not a fair comparison, but I think it's interesting. In patients with squamous cell histology, PD-L1 negative, if you look across the Nivo-IPI studies, the hazard ratios here are 0.53 or 0.48. Very small numbers here, compared to the Checkmate 407 study where we saw pembrolizumab added to chemotherapy. This was not significant in this patient subgroup with a hazard ratio of 0.78. So in patients with squamous cell histology, I do tend to use these Nivo-IPI combinations, but certainly the IPI-Nivo without chemotherapy is not approved by the FDA for use in PD-L1 negative disease. So I do tend to use a lot of Checkmate 9LA in this patient subgroup. So very small subgroup. Certainly for the adenocarcinoma patients with PD-L1 negative disease here, the hazard ratios really do tend to favor here the Keynote 189 data with a hazard ratio of 0.52. The median survivals are very similar across the studies here, but in the Checkmate 9LA study, this hazard ratio was not statistically significant. So I do still use PD-L1 to help try to guide me how to use immunotherapy in the advanced stage disease. So this is a whirlwind going from early stage disease, and this treatment is rapidly changing. I mean, literally by the day. Since 2020, we have now 3 different regimens to use. IO atezolizumab for PD-L1 positive disease in the adjuvant setting after surgery. Osimertinib targeted therapy in the adjuvant setting for patients with EGFR mutated disease after surgery. And now FDA approved neoadjuvant nivolumab plus chemotherapy. Obviously, I want to see all of the data as I would start to roll that out. So hopefully over the next month or so, we'll have even more data available to help guide therapy. And obviously, there's a lot of questions still to try to answer. What is better for patients, neoadjuvant therapy or adjuvant therapy? I'm excited that certainly this treatment setting is changing compared to the long time. I mean, 20 plus years where we didn't see any changes in this treatment setting. And then in locally advanced stage disease, consolidation durvalumab is standard of care. You cannot beat this. Clearly, there's a lot of questions about what to do in patients who have progressed while on immunotherapy or shortly thereafter, but I think we'll have some data over time. And then clearly in the advanced disease setting, while technically incurable, it is not the dismal treatment landscape of 10 years ago. We all most likely have patients in our clinic who are still doing alive and well, even off therapy years down the road since their diagnosis and treatment. So I'm happy to be able to say that I've been a part of all of this to be able to see how things can change. And I want to all thank you from the whole group at Johns Hopkins, and certainly give everyone some time to ask questions. But thank you so much for inviting me, and it's great to be back in Nebraska. And I hope everyone has a fabulous night.
Thank you so much, Dr. Bremer. That was a great presentation. I wanted to see if anyone had any questions for Dr. Bremer. Feel free to unmute yourselves or type those in the chat box.
This is Tiziana. I wanted to ask a few questions since I have you here. An awesome talk. That was crazy that you got it all in such a short amount of time. So you mentioned that, Nivo plus Ipi would be an acceptable strategy for the PD-L1 high expressors. And I think, I'm still struggling with the PD-L1 high expressors with the addition of CTLA-4 inhibitors. We saw the results of Keynote 598 that looked at Pembro plus Ipi in the high expressors. And that was the primary endpoint. And the study was totally negative, no improvement in OS, more toxicity. And so it makes me worried that this subset analysis of the checkmate studies, are flawed, and that perhaps there's a detriment there in adding a CTLA-4 inhibitor, period, for patients with PD-L1 high expressors.
Yeah, I do.
That.
Yeah, I think on the pembrolizumab study, it was, or it is negative in patients with PD-L1 high disease. I think the question will be, if we followed those patients out long enough, what happens with the tail of the curve there? Even though a short term, and the same with even the checkmate studies, while they were positive even on the short term, those differences are quite small. But the longer you get out, that tail continues to be higher compared to chemotherapy. But so we'll see. I think the 5-year data for checkmate will be helpful, but I too agree with you. I'm hard pressed to use CTLA-4 combinations in the PD-L1 high disease when I have a single agent that I'm completely comfortable with giving with pembrolizumab. And obviously, if I really need a response, I'm adding chemotherapy to that with a much higher response rate. So.
I have another question, adding the Poseidon data now with chemo plus another CTLA-4 inhibitor, Tremi plus Durva PD-L1 inhibitor. And, you showed the really impressive hazard ratios in the squamous population, PD-L1 negative, in the checkmate data. And then when we look at the Poseidon and look at the squamous histology in the PD-L1 negative, that didn't really match up. What do you think about that? And does that change how you view adding CTLA-4 inhibitors for the PD-L1 negative squamous population?
Yeah, I'm still using checkmate 9LA in the squamous population quite a bit. Yes, with the Poseidon data, there is some question in my mind about the activity of tremelimumab itself compared to ipilimumab. While these are both CTLA-4 antibodies, as a single agent, the tremelimumab has some issues even with in the melanoma setting. So I do question about whether or not that's an appropriate antibody. But I guess for the nivolumab and ipilimumab, I do feel that I'm seeing longer, at least for using the checkmate 9LA combination, I'm seeing a longer disease control with that regimen in the PD-L1 negative disease. I don't know about you. I mean, I don't think any of us use a ton of ipilimumab plus nivolumab, but I think in the PD-L1 negative disease group, I'm really looking for anything that can give those patients an advantage.
I agree. The last question I have for you is the long-term responders and re-challenge. We saw the Pembro Keynote 24 5-year overall survival. We saw the re-challenge for those patients that completed 2 years. The response rates are lower. Yes, there are responses. Should those patients actually be getting chemo IO versus IO alone? Do you think that data in itself with what we have now is convincing enough that you can re-challenge with Pembro monotherapy again?
Yeah, I think, the response rates were, like half of what what they originally had. You know, so I think if you know, if they've been off of therapy, it wouldn't hurt to try that, but certainly I'd have a low threshold to add chemotherapy to it. But obviously that's shooting at the hip, not using a ton of data, but trying to get a response in order to get their disease under control. Obviously, we need more studies in this setting, and even more in those patients with treatment refractory disease that their disease progresses while on immunotherapy. So.
All right, and we do have one question in the chat box from Dr. Silverstein. Length of time for immune therapy in responding patients for metastatic non-small cell lung cancer.
Yeah, so trying to decide when to stop or whether to continue, you know, we don't have a lot of great data. Their checkmate 513 in the second line treatment setting looked at stopping early versus continuing, and it was not a perfect study, but did favor continuing therapy until progression. Clearly, right now we all tend to stop at 2 years just because, but I do think there will be studies that will be using CT or cell-free DNA that might be able to guide us in the future. And those studies are being done to try to see, you know, if someone clears their their cell-free DNA or ctDNA, could we stop earlier and then use that to follow them and then restart it? Or do we just continue? I do have a few patients that have continued on with pembrolizumab, but that's a minority. Most of patients are ready to stop after 2 years and even have a hard time getting to 2 years just because of fatigue. So certainly it's something to keep in mind. Tiziana, your thoughts about that?
Yeah, I agree. I generally stop at 2 years. I will say that, you know, with the every 6-week dosing of pembrolizumab, it really has helped patients being able to like complete out the 2 years. At the end of the 2 years, there have been a few patients who have PET positive disease, who have active residual disease. This is not standard to do PET scans. They may be getting it for a variety of reasons. But, you know, I think the biggest challenge is if they have PET activity and residual disease there, do you keep going or do you stop and see what their immune system is able to do? In those cases, if there is room for radiation and there's active disease, I've tried doing that versus having a discussion about continuing and, you know, watching. So it's a tricky situation. And I do think that we need more studies in the when to stop immunotherapy. Some patients are attached and have a hard time stopping too. So it's having that discussion and preparing patients for that 2-year mark. But it's a good problem to have.
Definitely.
All right, do we have any other questions for Dr. Brommer? All right, seeing none, Dr. Brommer, thank you so much for spending your evening with us. And I hope that you enjoy your trip out here in Nebraska.
Thank you.
And with that, we'll move on to a 10-minute break where we'll be able to visit our virtual exhibitors. And just as a quick reminder, you know, please take this 10-minute break to visit our exhibitor booths. Their representatives are at each booth and can speak with you live. There's a chat function. And remember that we are competing for a $100 gift card if you can send me 5 of the unique competition codes from the exhibitor booths to my email before the day is over. I'll put the link again in the chat. And we'll take a quick break and we'll be back and we'll have Dr. Leal speak to us about small cell lung cancer. All right, everyone, I hope that you've had a chance to visit all of our exhibitor booths. And with that, I want to now introduce our second speaker of the night, and that is Dr. Tiziana Leal. And she is currently an associate professor in the Department of Hematology and Medical Oncology and the director of Thoracic Medical Oncology program at Emory University School of Medicine. Dr. Leal is a board certified in medical oncology and palliative care, and specializes in caring for patients with lung cancer, mesothelioma, and thymic malignancies at the Winship Cancer Institute. Before joining Emory, Dr. Leal was a member of the faculty at UW Carbone Center, Cancer Center in Madison, Wisconsin, where she served as a team leader of the Thoracic Malignancies Disease-Oriented Team. Dr. Leal received her medical degree from the Federal University of Ceará in Fortaleza, Brazil, and she completed her residency in internal medicine at the Weiss Memorial Hospital in Chicago. She completed a fellowship in geriatric medicine at the University of Illinois in Chicago and a fellowship of medical oncology at the University of Wisconsin Hospitals and Clinics in Madison, Wisconsin. Dr. Leal's clinical research focuses on clinical trials of chemotherapy and/or immunotherapy agents to treat cancers of the lung. She has authored or co-authored numerous peer-reviewed original research articles, book chapters, and posters. She is also serving as an associate editor and as a member of the executive editorial board of the Journal of the National Comprehensive Cancer Network. And she also serves as a lung cancer section editor of the Current Treatment Options in Oncology and on the editorial advisory boards of Cancer and the Brazilian Journal of Oncology. And with that, Dr. Leal, thank you so much for joining us tonight.
Thank you. Let me pull up my slides. Well, I'm very happy to be here today. I'm one of the newest members of the team here at Emory. I just moved to Atlanta in September of 2021. And so this has been, a good transition for me. And I work with Dr. Bramer through many research endeavors, including through our cooperative group, ECOG Akron, that she is the chair of. So today, for my talk, we're going to be focusing now on the current management of small cell lung cancer. These are my disclosures. And so let's talk about small cell lung cancer. We know that that's thankfully decreasing over time. It's, about 10 to 15% of lung cancers. But to put it into perspective, this is still a very deadly disease and it metastasizes early. And the majority of patients, unfortunately, are diagnosed with advanced or metastatic disease. CT screening that has improved, survival and early detection in non-small cell lung cancer hasn't really made an impact in small cell lung cancer. When we treat it, we see that there's initial chemosensitivity and responses. However, the disease becomes rapidly resistant. And there is a paucity of therapeutic options until most recently, where we've had some breakthrough with some improvements in outcomes that we'll talk about today. However, there's currently no targeted therapies with established efficacy, and we still don't have any validated biomarkers to guide treatment selection. And I put out this TNM classification with clinical stage and pathologic stage, just to put into perspective here that the 1-year survival for stage 4 small cell lung cancer or extensive stage small cell lung cancer is 22%. And so one of the most recent studies that has really changed how we treat small cell lung cancer was Empower 133. This study investigated the addition of atezolizumab, a PD-L1 inhibitor, in combination with our chemotherapy backbone, carboplatin and etoposide, versus carboplatin and etoposide in combination with placebo. So this was a phase 3 randomized double-blind study that enrolled patients that were treatment naive to the strategy of chemo IO versus chemotherapy plus placebo. This was a positive study, meaning it met its primary endpoints of both overall survival and progression-free survival. The median overall survival in the experimental arm was 12.3 months versus 10.3 months, with a hazard ratio of 0.76. And now with longer follow-up, with a median follow-up of 22 months, there's an established and sustained benefit for a subset of patients with the addition of atezolizumab to chemotherapy. And you're seeing here an improvement in 1-year overall survival. Remember, we said 22%, and now we're seeing 51.9% in the patients with chemo plus immunotherapy. And at 18 months, we're seeing 34% versus 21%. On the right lower, what you're seeing here is the subset analysis of key subgroups to really show that this regimen led to improvement in OS in the majority of the key subgroups, including in patients who had evidence of liver metastasis or not, and also looking at blood TMB. We talked about the use of PD-L1 expression as a biomarker for non-small cell lung cancer. For small cell lung cancer, it's been more difficult to establish a biomarker. Number one, because tissue is very hard to obtain. Patients present with a lot of, medical problems or rapidly progressive disease. So one strategy that we used in Empower 133 was to use a blood-based biomarker with blood TMB. Using different cutoffs, as you can see here, 10 or 16, really didn't make a difference. So here, what this tells us is that this regimen really benefits a subset of patients. There's a tail of the curve there. However, there's no biomarker and it's approved for an all-comer population. Here's another study that also led to the approval of another PD-L1 inhibitor, durvalumab, in combination with chemotherapy. Similar study design. This was, again, another phase 3 study evaluating durva plus chemo versus chemotherapy alone in patients with untreated extensive stage small cell lung cancer. This study is the one with the longest follow-up. We have now median follow-up here of 39.4 months. And as you can see here, the median OS is statistically significant, a modest improvement similar to what we saw in Empower 133, with a median OS of 12.9 versus 10.5 months. And here, looking at the tail of the curve, at the 36-month landmark analysis, 17.6 versus 5.8. But I'll bring you back to the 12-month OS here of 52% versus 39%. So we're making strides, modest benefit for all comers. However, we can't really tease out who are the patients, who are the people who are benefiting the most from this strategy. And so we also looked at the addition of a CTLA-4 inhibitor in small cell lung cancer. In the Caspian study, one of the arms was the addition of tremelimumab, a CTLA-4 inhibitor in combination with durva plus chemo, the comparator here being chemotherapy, the carboplatin etoposide arm. This actually did not meet its primary endpoint. The median OS here is similar between the two arms, as you can see here, 10.4 months in the durva plus tremi plus chemo versus 10.5 months in the chemotherapy alone arm. And the hazard ratio here is 0.81. So even though you see numerically there is an improvement, this is not statistically significant, did not lead to the approval of this regimen in small cell lung cancer. And one important thing to point out is that this combination strategy is associated with more toxicity. So there were more adverse events leading to treatment discontinuation with the strategy of durva plus tremi plus chemo, 21% versus 9%, and more grade 5 adverse events, which is death due to treatment, 10% versus 6%. So for patients that are all comers, durvalumab plus tremi plus chemo should not be used in clinical practice. And here's another strategy trying to add CTLA-4 inhibitor to this treatment strategy with chemotherapy, followed now by maintenance. So patients with untreated small cell lung cancer who receive initial therapy with the chemotherapy backbone, then go on to receive either nivolumab, a PD-1 inhibitor, versus nivo plus ipi versus placebo, with co-primary endpoints here of overall survival and progression-free survival. And once again here, the comparator was nivo plus ipi versus placebo, and this was a negative trial. The addition of nivolumab plus ipilimumab in the maintenance setting did not lead to improved overall survival, and this is not an approved strategy either. So far, really no established role for CTLA-4 inhibitors either in induction or in the maintenance setting for patients with small cell lung cancer. So here's a summary of the trials of chemoimmunotherapy in small cell lung cancer. We actually now have 2 trials that have led to approvals, IMpower 133 with the approval of atezolizumab. We have the approval of durvalumab with the Caspian study. We also saw the results of Keynote 604 investigating pembrolizumab in combination with chemo versus chemotherapy. This study led to an improvement in progression-free survival. However, it did not meet statistical significance for overall survival. But you can see here that the 12-month OS is similar across the board from a numerical standpoint. And then I'm highlighting EA5161, which is a study that we conducted through ECOG Akron, investigating nivolumab plus chemo versus chemotherapy. This was a study in the phase 2 setting, and it also met its primary endpoint, but did not change standard of care given that it was in the randomized phase 2 setting. And at that point, we already had 2 regimens in the phase 3 with positive results. However, it does establish 2 things. Number one, chemoimmunotherapy is the standard of care for patients with extensive stage small cell lung cancer. It's approved for an all-comer population, meaning we don't have a biomarker, and the majority of patients do seem to derive some benefit from it. There are a few exceptions. I would say patients who have immunosuppression that require active therapy for their autoimmune disease, patients who maybe have transplant, or patients who are just too sick and are treated in the hospital that don't have time to get the benefit from immunotherapy. So chemotherapy alone in that initial setting is the way to go. One important thing to point out is that these regimens actually added chemo and immunotherapy in the induction phase, meaning the first 4 cycles of chemotherapy. And then patients go on to receive the maintenance strategy with monotherapy, either atezo or durvalumab. And that's a strategy that is what we use in current clinical practice. But here's again, sort of just a summary of all of our efforts to try to find a biomarker for small cell lung cancer. PD-L1 expression in small cell lung cancer actually is low, meaning it's very rare to see high PD-L1 expression. And importantly, tumor PD-L1 expression just was not predictive of benefit in both the IMpower study as well as the Caspian study. One thing to point out is the biomarker evaluable population is only about a little over half, because a lot of these studies were not able to get enough tissue to do these really, detailed studies. But we also tried looking at the TMB in the blood to try to overcome that problem with the tissue. And again, important to note that both in the IMpower as well as in the Caspian study, blood TMB really was not predictive of benefit for chemoimmunotherapy in extensive stage small cell lung cancer. So no biomarkers at this time to predict who will get the most benefit from this strategy. So a regimen approved for all comers. So looking again at biomarkers, we really want to figure out, is there a differential effect on therapies for patients based on other strategies? We saw that for small cell lung cancer, using NGS or tumor genetics hasn't really panned out to identify patients who could be selected for targeted therapies. One strategy that in preclinical setting seems to have a signal here is the classification of small cell based on small cell lung cancer subtypes. These are transcriptionally identified subsets with presence or absence of neuroendocrine markers. And as you can see here, we've identified 4 subsets. And at the bottom, what you're seeing is preclinical work that's been done showing that perhaps there's some therapeutic implications of these subsets. And I'll point out, for example, the YAP1, which is the inflamed subtype that so far is looking like there might be a signal that this might be the subtype most likely to benefit from the strategy of chemoimmunotherapy. And then the other subtypes, as you can see there, may have some signal in terms of other strategies that are very early on in development. So this is not ready for prime time. This is exploratory in nature, but really seems to be the way to go. And we're starting to look at this in a prospective fashion in clinical trials. So this is some of the exploratory work that has been done. Dr. Winakoko from Emory looked at small cell lung cancer tumors and identified two important messages. One was that the YAP1 expression, YAP1 high tumors were more likely to be seen in patients with limited stage small cell lung cancer who have better outcomes, perhaps a different biologic behavior, suggesting that YAP1 expression may be prognostic. And then in addition, we looked at Empower 133 and saw numerical improvement with the addition of immunotherapy to EP versus the strategy of EP plus placebo. That's the small cell lung cancer eye. As you can see there, the median OS is 18.2 months versus 10.4 months. So again, a numerical improvement with the inflamed subtype in immunotherapy, certainly not ready for prime time and not conclusive, but further studies I think are warranted to try to confirm if that really is the case. So looking at additional studies, again, exploratory in nature, they did a subset analysis of Empower 133, which was the atezo plus chemotherapy study. And they looked at gene expression analysis in what they define long-term survivors from Empower 133. And they showed associations between differential gene expression and these small cell lung cancer subtypes based on RNA-seq data. So just to really summarize this presentation, what they showed was that the long-term survivors, which were defined as living 18 months or longer, were numerically higher and statistically significantly higher in the atezo plus chemo arm. There was sort of, in the long-term survivors, there was representation of all the different subtypes. However, there was enrichment of the small cell lung cancer eye or the inflamed subtype in the chemo plus atezo arm. So again, exploratory in nature, but very interesting and something that we're looking forward to learning more about. But where do we go from here? How do we improve on the outcomes and really strategize in terms of next steps in further developments of new therapies? One of the biggest strategies that is ongoing is adding novel immunotherapy agents to the backbone of chemoimmunotherapy to really enhance the immunotherapy response, given the resistance that we see in small cell lung cancer. Other agents looking at turning cold tumors hot is adding DNA damage repair, like PARP inhibitors. We're looking at other agents at growth and signaling and epigenetic regulators, and new biomarkers are ongoing as well. So one of the, I think, most advanced in development is the addition of a new agent to this backbone of chemoimmunotherapy. This is tiragolumab. Tiragolumab is an anti-TIGIT antibody, which by blocking TIGIT, you're actually activating the immune system and hoping to synergize with immunotherapy. This is a randomized phase 3 study looking at the primary endpoint of progression-free survival as well as overall survival. This study has actually completed accrual and we're waiting for readout, hopefully sometime this year or early next year. Another study that is currently ongoing now in the randomized phase 2 setting is adding a new agent called BMS 986012. This is an agent that is an antifucosal antibody, a different mechanism of action, and binding of BMS to tumor cells activates the antibody-dependent cell-mediated cytotoxicity, the complement-dependent cytotoxicity, and is postulated to increase T-cell anti-tumor activity and enhance the activity of nivolumab, the PD-1 inhibitor. This combination of BMS plus nivolumab has been investigated in a phase 2 setting, showing durable responses and really acceptable and manageable side effects, the main one being pruritus. So this is an ongoing randomized phase 2 study looking at the combination of BMS plus nivo plus chemotherapy followed by maintenance, and this study is also ongoing. Well, what about adding PARP inhibitors? We have investigated the use of PARP inhibitors in all comers, both in addition to chemotherapy, as well as in addition with, for example, alkylating agents like temozolomide. The phase 2 efforts overall demonstrated negative primary endpoints, but they went back and looked retrospectively at these samples and identified a biomarker called Schlafen 11, which is seen in about 50% of patients with small cell lung cancer and saw a higher benefit in patients who had SLFN11 expression and got the PARP inhibitor. So this signal was strong enough that we're actually moving it into prospective studies and using it as an integral biomarker. This is a study that is a SWOG cooperative group study investigating patients who have small cell lung cancer. They get their initial first therapy of carboplatin etoposide, atezolizumab. They are then assessed whether or not the tumor has the biomarker SLFN11. If they do and have evidence of stable or better response to their initial treatment, they're then randomized to either the standard of care arm, which is maintenance atezolizumab, versus the combination of atezolizumab and talazoparib, which is a PARP inhibitor, which is approved in other disease types. What about, again, using the strategy of turning cold tumors hot, adding radiation? So this is a strategy, LU007, which is a study from the NRG, where patients receive their standard chemoimmunotherapy, and then they're randomized 1-to-1 to radiation to up to 5 sites of disease in combination with atezolizumab, followed by atezo maintenance versus atezolizumab alone. And this study is also ongoing. So moving on to, how about limited stage small cell lung cancer? Can we move IO up front? We've seen the benefit of adding immunotherapy in the advanced setting. What about in limited stage small cell lung cancer? For limited stage small cell lung cancer, the standard of care is, in general, the combination of chemotherapy using cisplatin and etoposide with radiation. And the standard regimen is radiation, thoracic radiation twice daily for 3.5 weeks. We call that the Teresi regimen. But even with that aggressive strategy, the majority of patients recur. So the sort of next step, and made total sense, is to create this study, the NRG LU005. We're actually investigating the addition of immunotherapy, atezolizumab, in a randomized phase 3 fashion in the limited stage small cell lung cancer setting. This study is ongoing and is actively accruing patients, and we should hopefully see results over the next couple of years. We're also looking at the addition of durva plus tremi in the Adriatic study in the maintenance setting after concurrent chemoradiation. So these are areas of active investigation. One of the areas that is really an area of unmet need is when patients have relapsed small cell lung cancer. So they have their initial treatment with carboplatin etoposide atezolizumab, and then now they have perhaps a response. We see that the progression-free survival in the atezolizumab maintenance studies is about 6 months. So it's not a matter of if they'll recur. The majority of patients, unfortunately, will have relapsed small cell lung cancer. And this is the NCCN guidelines, just to show you how many agents we actually have on the guidelines. This is not very common to have this many options, but I think it shows how difficult it is in this relapse setting and the lack of definitive guidance on what is the best strategy for patients with relapsed small cell lung cancer. And for the longest time, topotecan has been really the approved FDA regimen for patients with relapsed small cell lung cancer. It is a difficult regimen given the hematologic toxicities that patients face when they receive topotecan, and the response rates are low. You know, the response rates in the patients who have sensitive disease, which we defined as having platinum and then having progression 6 months or greater, is about 20%. For the patients who are platinum refractory, the response rates with topotecan are even lower, and the response rates are about 10 to 15%. So we saw the results of it was not a randomized, it was actually a single arm basket trial looking at a new agent called lurbinectedin. Lurbinectedin has a really novel mechanism of action. This is a selective inhibitor of oncogenic transcription that we now have approval of based on this study, which is a single arm basket study that investigated lurbinectedin at the dose of 3.2 milligrams per meter squared every 3 weeks. And in this study, the primary endpoint was overall response rate. And I'll focus on the cohort of patients with small cell lung cancer. Please note here that in this study, they allowed 1 prior chemotherapy line, prior immunotherapy was allowed, but this study was conducted before chemoimmunotherapy was widely available because this was a global study. So here are the efficacy endpoints of lurbinectedin in small cell lung cancer. The study did meet its primary endpoint. The overall response rate here is pretty encouraging, with an overall response rate of 35%. And not surprisingly, the response rates are higher if patients have platinum sensitive disease, in the order of 45%, and lower if they have platinum refractory disease. Similarly, here the overall survival is improved, in patients who are platinum sensitive versus resistant. You can see the overall survival there at 12 months is 48% in the platinum sensitive, 15% in the resistant, and 34% in the all-comer population. So this is a regimen that's approved for patients with relapsed small cell lung cancer. I would say that it looks very favorable in terms of response rates, and specifically more in the platinum sensitive population. So the next study was the Atlantis study that was recently presented at World Lung 2021. This study looked at patients with small cell lung cancer who had prior chemotherapy. They had performance status of 0, 1, or 2, and they were randomized to doxorubicin in combination with lurbinectedin. Please note here that the dose of lurbinectedin is lower than what we use in monotherapy, 2 milligrams per meter squared every 3 weeks, versus a standard of care of topotecan or CAV. The primary endpoint of this study is overall survival. This study was disappointingly negative. The Atlantis trial does not change our standard of care. The combination arm with lurbinectedin plus doxorubicin versus the standard of care had a median OS of 8.6 months versus 7.6 months, with a hazard ratio of 0.9. Also, the PFS was negative, and there is really no significant difference there in terms of PFS, with a median PFS of 4 months in both arms. In addition, the toxicities were very comparable, less hematologic toxicities in the Atlantis trial. So this was another study that was done looking at nivo versus topotecan in relapsed small cell lung cancer. We had approval of nivolumab and pembrolizumab in second or third line based on the initial studies, and it was mainly based on durability of response. So this is a randomized phase 3 study that was really trying to answer the question of what should we be using in second line? And unfortunately, this was a negative study. Nivolumab versus topotecan, as you can see there, in the overall survival graph, the one on the left, nivo is red and chemo is green. The overall survival was actually better with topotecan versus nivolumab. The PFS was better with chemo versus nivolumab. So this study did not meet its primary endpoint of overall survival with nivolumab versus chemotherapy. And chemotherapy with topotecan, I would say, is certainly still the standard of care for patients in the relapse setting. And lurbinectedin is also another option that's FDA approved. However, the randomized phase 3 study was, disappointingly negative. And I think the next efforts are really to do a study looking at topotecan versus lurbinectedin in the relapse setting. And that study is ongoing. Additional efforts in the relapse setting. We use irinotecan in relapsed small cell lung cancer. We know that irinotecan has activity in small cell. We use it in the frontline setting at times for patients with platinum plus irinotecan. There was a randomized phase 3 study in Japan that showed improved overall survival with that regimen. This is a novel formulation of irinotecan. This is liposomal irinotecan. And in the phase 1-2 strategy, as you can see here on the left, the response rates were very encouraging for irinotecan, with response rates of 44% with irinotecan. And there's an ongoing study in the randomized phase 3 setting that has already completed accrual of liposomal irinotecan versus topotecan. We're also looking at novel agents and novel ways of targeting small cell. A target that we've investigated for many years now is DLL3. We know that patients with small cell lung cancer have expression of DLL3. There was an effort looking at Rova-T, which targeted DLL3. We saw that there was activity of Rova-T in small cell lung cancer, but further development was halted because of increased toxicity. But now we have these agents called BiTE agents, which have a different mechanism of action. They engage with the T cells and target the DLL3. And we have very early data here with tarlatamab, which is an agent that targets DLL3, showing encouraging overall response rate of 30% at higher doses, with encouraging median duration of response of 8.7 months. And the experience here is early on, but the toxicities have been manageable and mostly cytokine release syndrome from these agents. So more to come on tarlatamab. So in conclusion, chemoimmunotherapy is the standard of care in frontline extensive stage small cell lung cancer. This is a regimen that's approved for the all-comer population. Biomarker definition is needed to really identify patients that are most likely to derive benefit from chemoimmunotherapy. We're looking at small cell lung cancer subtypes, and the inflamed subset seems to be associated with perhaps a signal of improved efficacy with immunotherapy, but we're waiting for prospective validation. And lurbinectedin as a single agent remains an option for salvage therapy, preferably with patients that have platinum-sensitive disease. Thank you very much. I'm open for questions.
All right, do we have any questions for Dr. Liao? Feel free to either unmute yourselves or type those in the chat box. All right, well, if there are no questions for Dr. Liao, thank you so much for joining us this evening and sharing your time and expertise with us. We really do appreciate you joining tonight's talk.
Thank you, everyone. Have a good night.
Thank you. All right, everyone. With that, again, want to thank Dr. Liao for her time today. Just a few announcements before we end the session. The Nebraska Oncology Society is proud to announce that the dates for the evening speaker series throughout the year and our Midwest ASCO review have been set. As a reminder, if you have not yet renewed your membership, please go ahead and do that. We're still underway without you losing any of your benefits through the end of the month. And if you have any partners or anyone else that you think should be a member, please encourage them to join our society. It's important to hear everyone's voices, especially when it comes to advocacy for our patients. There's a lot going on right now with the legislature. Happy to report that there was a white bagging bill that I had emailed everyone about, and that actually got voted out of committee. So positive step for patients in Nebraska. And then with that, thank you everyone for your participation. We've reached the end of the event. I also want to thank not just our speakers, but also our exhibitors for tonight. Our corporate members are a big part of how we're able to do what we can in order to promote and advocate for patients and also help support cancer education for everyone in Nebraska. So thank you again and enjoy the rest of your evening. Thank you.